So, good morning. Today's topic for discussion is about anchorage in orthodontics. So, the anchorage, the word anchorage it's actually derived from the anchor, which is used for holding the ship in sea. This is basically what the anchor look like. So, in orthodontics, whatever unit which resists the tooth movement or unwanted tooth movement uh, is known as anchorage. So moving on to the various content of this topic anchorage, this presentation includes the definition, classification, factors affecting anchorage, sources of anchorage, anchorage planning, different anchorages, anchorage demand and anchorage laws, and advancements in the field of anchorage, and the conclusion. So first let us see the definition. So basically what is anchorage? Any resistance to the unwanted tooth movement can be considered as anchorage. Okay, to understand the concept a little bit more better, you should know the Newton's third law of motion, that is, uh, for every action there is equal and opposite reaction. In the case of orthodontic tooth movement, this reactionary force may be detrimental for the overall successful orthodontic treatment. So we have to control that. So any factor that helps us to control this reactionary force can be called as an anchorage unit. There are various definitions for anchorage, but most commonly used definition is given by Graeber. So, according to him, the anchorage can be defined as the nature and the degree of resistance to the displacement offered by an anatomic unit when used for the purpose of affecting tooth movement. Simply, it is the resistance offered to the movement. And yet another definition by White and Gardner, the site of delivery from which the force is exerted is considered as anchorage. Okay, there are various classification for anchorage depending upon the factors like how the site, what is the site of anchorage, what is the manner of force application, and according to the jaws involved and number of anchorage units. So according to the site of anchorage, the broadly anchorage can be classified as intraoral, extraoral, and muscular anchorage, and we can see it in detail in the following slides. And manner of force application, the anchorage can be either simple, stationary, or reciprocal, and based upon the jaws involved, intramaxillary and intermaxillary anchorage. Number of anchorage unit, the anchorage can be classified as single or primary, compound, multiple, or reinforced anchorage. So, what is the basic difference between the intraoral and extraoral sources? As the word itself suggests, intraoral means the anchorage unit when it is present within the oral cavity, that is intraoral, and extraoral when the anchorage is derived from any source outside the oral cavity, they are extraoral sources. So, what are the intraoral sources? Yes, the first thing is the teeth. So any teeth that can be incisor, canine, premolar, molar, depending upon the type of tooth movement required, any of these tooth can be an anchorage unit. Okay, so we can consider the teeth as the intraoral anchorage unit. Then there is alveolar bone, cortical bone, basal bone. So the alveolar bone also provide resistance to the tooth movement, that can be considered as an anchorage unit. And the cortical bone. So when the tooth is abutted to the cortical bone, it offers more anchorage. So that the teeth further resist the movement. Okay, and there is yet another type of anchorage. So basically we have explained in the prior slide, these are the alveolar bone, basal bone, both offers the anchorage. Degree of anchorage offered by the basal bone is more compared to the alveolar bone. And next, moving on to the extraoral sources. So the anchorage which is derived from outside the oral cavities are the extraoral sources. So all the bone in the facial and cranial region can serve as an extraoral anchorage unit. For example, frontal bone, parietal bone, occipital bone, and especially most commonly the extraoral sources we are using either for anchorage enhancement, that is increasing the anchorage, or for the orthopedic appliances, which is used for the skeletal malrelationship corrections. Okay, then let us move on to what are the factors which affects the anchorage. Okay, the first factor we have to consider is about the teeth. So, what are the factors within the teeth that is affecting the anchorage? The first thing is the root surface area. What is root surface area? It is the overall surface area of the root. So, when we see this picture, the various tooth are having differing root surface area. Comparing the anteriors and posteriors, the root surface area for the posteriors are more because they are the bulkier, having bulkier roots, and comparing the maxillary and mandibular teeth are having less root surface area compared to the maxillary tooth. But see, uh, tooth size wise, actually mandibular first molar is the largest tooth, but the root surface area is maximum for the maxillary first molar, because maxillary first molar is having a three root tripod root arrangement. So as the number of root increases, the root surface area also increases. So maxillary first molar provides more resistance to the tooth movement than the mandibular first molar. Next factor which affect within the root is that root form. That is, root form means what is the shape of the root. So when we take the cross section, the root may be in different shapes. It may be round, it may be flat or triangular. So according to the form or shape of the root, the anchorage offered by this tooth can change. So round tooth basically maxillary anteriors, maxillary first molar, and palatal root of the maxillary first molar has the round root section. So as it is round, the resistance of movement in any direction, that is either mesial, distal, buccal or lingual, the resistance offered for the movement in any direction is same for the round tooth form. And the flat teeth, basically mandibular incisors and buccal roots of the maxillary molars, having the flat root, that the tooth resists more in the mesiodistal direction. And for the triangular root, example maxillary canines and lateral incisor, they are having a triangular arrangement. So this triangular root offers greater resistance to the movement. As we already discussed, as the number of the tooth increases, the surface area will be more. So as the more surface area is present, the resistance offered will be more. So the posterior teeth, which are having lar more number of roots and the larger size of the root, offers greater resistance than the small anterior tooth with small roots. And the next factor which affect is the length of the root. Okay, so it is basically we are considering how much root is within the bone. So when the length of the root is more, which is embedded within the bone, the resistance offered will be more. So considering canine, it is having the largest root and it is more embedded to the bone. So canine can have better resistance to the movement than the anterior teeth. And next factor is the inclination of the teeth. So if we are pulling the tooth mesially, okay, if the force is directed mesially and the direction or inclination of the tooth is like tilted distally, that tooth can offer better resistance compared to the tooth that is inclined or inclined mesially. So that axial inclination of the tooth also plays a role in the degree of anchorage. That is, axial inclination is when the axial inclination is in the opposite direction to the force applied, greater resistance. So when we are preparing anchorage in previous times and all, we used to tip the posteriors distally so that it offer better anchorage. And the next factor we have to remember is that about the ankylosed tooth. So for that we should know what is ankylosis. What is ankylosis? Ankylosis is the bony fusion of the teeth, where the teeth is directly attached to the bone without a pedial fiber or pedial space. So tooth is basically cemented or attached firmly to the bone. So without pedial fiber, there is no tooth movement. So these teeth can provide absolute anchorage. They cannot be moved with the orthodontic force, or any kind of force cannot displace these teeth. So that is the importance of this teeth. So when we are having an ankylosed tooth, the resistance offered by this tooth is like absolute. There won't be any anchor loss. Now we can see in details the various type of anchorage we have already seen in the classification. So the first classification was based upon the manner of force application, that is simple anchorage. What is simple anchorage? That is when the manner of force application is such that it tends to change the axial inclination of tooth or the teeth that forms the anchorage unit in the plane of space in which the force is applied. That is, simple anchorage is obtained by engaging a greater number of teeth that are to be moved. Okay. So next is stationary anchorage, when the application of force tend to displace the anchorage unit broadly in the plane of space. In the simple anchorage, it was like uh, uh, tipping tipping movement, but in the stationary anchorage it is broadly in the plane of space in which the force is being applied. The anchorage potential of the teeth being moved broadly is considered greater as compared to the teeth that is being used as a tipping force. So for a tooth to have a broadly movement, we have to apply more amount of force. So that means the resistance offered to the broadly movement is more. And next is an important type of classification, that is reciprocal anchorage. Reciprocal anchorage means, as the word reciprocal, like when we in all other cases there is an anchorage unit and a reactionary, that is moving unit, that is stationary unit and a moving unit. In reciprocal anchorage, the sets of tooth act as both anchorage and the moving unit. When two teeth or two sets of teeth move to an equal extent in the opposite direction, like when we are closing a midline diastema, that in the second picture we can see finger spring used for closure of the midline diastema. Okay, so when we consider the tooth in the right side, the tooth is being moved to mesial direction, and in the left side the tooth is moving to the both, they are actually moving mesially to close the midline diastema. But when we consider individually, when one teeth is moving mesially, the other teeth is actually offering a resistance to that movement, that is actually acting as an anchorage unit. At the same time it is moving also. So that kind of anchorage is known as reciprocal anchorage, and this reciprocal anchorage can be in any direction, that it can occur in the vertical, anteroposterior or transverse direction. So when we are considering the midline diastema closure, actually it is occurring in the transverse plane. And when we are correcting cross bite, we are in the first picture when elastics are used through the bite, that is when the elastic pass from the lingual or palatal aspect to the buccal aspect, that is through the bite. When the elastic are moving for the correction of cross bite, actually what's happening, one unit which is acting as the anchor unit is becoming the moving unit also to correct the cross bite. So when the elastic is attached from the buccal aspect to the palatal aspect, in the maxillary arch the teeth is going moved buccally, and in the mandibular arch the teeth is actually moving lingually. But at the same time they both are offering an anchorage to the opposite teeth's movement. Okay, that is in the transverse plane. And in vertical plane where it occurs, that is in the correction of the deep bite or open bite, it occurs in the vertical plane, the same thing. The anteroposterior, when we are correcting camouflage, that is class 2 or class 3 conditions as a camouflage situation, this reciprocal anchorage occurs, that is effect of the forces exert equally, both are moving equally. And according to the Joe, the anchorage can be classified as intramaxillary anchorage and intermaxillary anchorage. So intramaxillary means that is within the same arch. So if the moving tooth and anchorage tooth are in same arch, that is in, for example, maxilla, it is intramaxillary, or in the mandible it is also intramaxillary, that is same arch. Just you need to remember like same arch where the anchor unit and the moving unit are in the same arch. Intermaxillary means when the moving unit is in one arch and the anchorage unit is in the other arch, they are intermaxillary anchorage. The other name for intermaxillary anchorage is Baker's anchorage. It's very important, you have to remember the term Baker's anchorage. So the Baker's anchorage can be either a class 2 anchorage or class 3 condition. Okay, so for the class 2 correction, we give the elastics from the mandibular molars to the maxillary anterior region for the retraction of maxillary anteriors, and we need the slight protraction of the mandibular molars, that is class 2 intermaxillary elastics or class 2 anchorage can be considered, and it's in the anteroposterior direction. And in the class 3 case we run elastics from the maxillary posterior region to the mandibular anterior region. So remember the term Baker's anchorage, which is the anchorage that is occurring in the anteroposterior plane. It's an example of reciprocal and it is an intermaxillary anchorage. Next classification we have seen the simple, compound, reinforced. Simple means for the single tooth, compound where there is multiple, and for reinforced or multiple, that is extra additional source of anchorage we are using. See, when you have already seen the extra oral anchorages. So when the intraoral source of anchorage are not adequate for the adequate tooth movement, we may require extra anchorage from the any other additional structures. They are extraoral fossa or extraoral structures, parietal bone, frontal bone, occipital bone. We may need to include it into our anchorage situation. So that is known as reinforced or multiple anchorage. We are just reinforcing the anchorage, adding different anchorage unit for the better anchorage value. And when we are giving upper anterior inclined planes, that is weight planes, for the correction of class 2, that is to reduce the over jet condition, it also acts as a controlling factor for the tooth movement, so it can be considered as a reinforced anchorage. Uses of transpalatal or lingual arch. Transpalatal arch or Gaucherian arch, where there is the first molars are banded and a wire is running between these first molars in the transverse direction. It's actually providing anchorage which is restricting the movement of the first molar. So this transpalatal or lingual arch, which is running from the mandibular posteriors to the lingual surface of the lingually through the teeth to the other side molar, it also provides additional anchorage. So when there is situation for increased anchorage need, like group A condition where there is more of retraction or correction in the anterior region is needed, we can use this anchorage, additional anchorage units. Then this is very important for the proper treatment, that is anchorage demand. The anchorage demand can be of three types, that is maximum anchorage, moderate anchorage, minimum anchorage. Maximum anchorage means like maximum anchorage is required. Okay, whatever possible anchorage site we can incorporate, we should incorporate it into the anchorage unit for the ideal or better tooth uh, movement or resolving the present condition. Moderate anchorage means some amount of anchor loss is permitted, and in minimum anchorage means anchorage preparation is undesirable because the movement of posterior is required. So when we need to think about this anchorage demand, mostly for the extraction cases. Okay, in extraction cases that we need about most of the space, about 70% of the space, 75% of the space we require for retraction. So that is a maximum anchorage case. So that not more than 1/4 of the extraction space should be lost by the forward movement of the anchor teeth, where we cannot permit more than 25% of forward movement of the anchor teeth. Okay, that is severe crowding condition and all. We cannot afford the forward movement more than 25% because it may result in improper correction of the crowding. So in the moderate condition, where we can permit about 25 to 50% of the extraction space by closure by the mesial movement of the molars and 50% retraction. And in minimum condition, when the anterior region where the situation is not severe, we may require the protraction or forward movement of the posterior teeth, where there is more than half the extraction space can be lost by the anchor teeth moving mesially. That is a minimum anchorage condition. So remember this: maximum anchorage, moderate anchorage, and minimum anchorage. Maximum anchorage means we require maximum anchorage. We cannot afford more than 25% of forward movement. Moderate anchorage means it's moderate, where we can afford about 25 to 50 percentage of the forward movement, and in minimum anchorage we can afford up to 75 percentage of the forward movement. Only 25 percentage may be required for the correction of condition. Now we should talk about the temporary anchorage device, which is an ice-breaking innovation in the field of orthodontics. Uh, in order to get a maximum anchorage, we should incorporate as much anchorage unit we can into get that maximum anchorage. So we may need to take extra oral anchorage sources, but in order to compensate this difficulty, now we have temporary anchorage devices. Okay, that is known as TADs, temporary anchorage device. Basically, they are orthodontic micro implants which are screwed into the bone and which provides an anchorage similar to the absolute anchorage. Okay, basically screws got mini screw got a head. uh, Sometimes it may have a hole for orthodontic wire engagement or one transgingival region and a screw region where there is a thread-like design and it is tapering towards the apical region. And the mini implants or mini screws can be of two types: self-tapping and self-drilling types of mini screws, and we require a screwdriver to put the screw into the bone. See, in this picture, you can see a temporary anchorage device put in between the premolars, and in this situation, actually, the spring is attached from the temporary anchorage device to the second molar to protect the molar anteriorly. And this condition, two tabs are put in between the roots of lateral incisor and canine to intrude the maxillary anteriors. That is basically for the correction of anterior divide. We may require the intrusion. When the visibility is more, we may require the intrusion of maxillary anteriors. So placement of two tags in between the lateral and canine root help us to intrude the anterior segment. There are different types of screws available. Classification can be made based upon the diameter of the screw and the length of the screw. The commonly used screws are coming in the length of 6 millimeter, 8 millimeter, and 10 millimeter, and head size from 1 to 2.4 millimeter. And so even though it's very useful, we should be careful about the possible complications with the placement of tags. That is when we are placing, as we are placing the tags interradicular, that means between the roots of two teeth, that may be a chance of contact with the adjacent root. So that we should be careful about that. The tooth should not be nicked by the tag. Next complication is breakage of implant. So if we are the most highly likely when we are first inserting the implant, and if maybe due to some factor, if we need to reinsert the implant, the same implant, the chance of breakage is more, and it is also more when we are taking out the implant improperly. And damage to the anatomic structure like vital structures, if the nerve blood vessels are passing adjacent or in the pass or course of the tag, it may damage the anatomic structures. And the tag is possessing a constant irritation to the gingiva soft tissue. So when the soft tissue is irritated, what happens? Hyperplasia, overgrowth of the tissues occurs. So when tags are placed, even with the proper technique, overgrowth of the soft tissue can occur. It may cover the tag. So we may require the excision of the soft tissue for the attachment with the elastic or spring. We need to excise the gingiva. And implant loosening. So loosening can occur due to various factors like improper placement or improper bone selection. If the density of the bone is less or the amount of bone is less, we cannot place the tag because it may get loosened, because some amount of dense bone should be there to hold the implant. So what is anchorage planning? It's very important. So if we need to get a proper treatment result, we should plan the anchorage prior. So before starting treatment, we should have an idea about number of tooth to be moved. If the number of tooth to be moved is more, we may require more anchorage. So we have to prepare the anchorage accordingly. So we may need to reinforce the anchorage. We may require to incorporate extra oral anchorages. And types of the tooth being moved, that is whether the tooth is being tipped or being moved boldly. When teeth is being moved uh, like tipping, the anchorage requirement may be less, and for the boldly movement, anchorage requirement is more. Okay. uh, Type of the movement required similar to that, and skeletal pattern, that is whether the patient is a vertical growth, having a vertical growth pattern or horizontal growth pattern. It differs the anchorage planning and occlusal interlocking. These things has to be considered while planning for the anchorage. And next is the anchorage loss, that is anchorage burn, anchorage slips. These are the other terms used for loss of anchorage. Loss of anchorage, even if we plan properly, there is chance of losing anchorage. So one of the thing we need to do to lose the correct the loss of anchorage, to minimize the loss of anchorage, is proper planning. But even though if we plan properly, there are chances of anchorage loss. So basically what is anchorage loss? Anchorage means that is a resistance of movement. So that tooth, which is that in case in this picture, the molar teeth or the posterior segment, second premolar, molar, first molar and second molars are acting as the anchorage unit. What we are expecting in this situation? We are expecting this anchor unit to be stable and the anterior segment should move at least to the 75% to close the extraction space. But in certain situation, if the force application or manner of force application is not proper or any other reason, there may be a forward movement of the posterior teeth, and if it is closing more than the accepted value of the anchorage loss, it may jeopardize the treatment planning. So we should always be careful about the amount of loss of anchorage. And this is basically we are coming I have to tell you about the anchorage. So whichever the case, whichever the condition, the proper planning of anchorage, or you should have a prior idea about how much anchorage you need, how you are going to achieve that anchorage, how you are planning the treatments, very important for the successful orthodontic treatment. So you should always consider about the anchorage, and you should be able to use the newer methods of anchorage, that is that when even if we are using a temporary anchorage device, we should be aware of the complication and should be able to manage it accordingly. So that is all about the anchorage. Thank you.